Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today we're plunging into a condition that can really swiftly turn a routine surgical admission into a pretty high-stakes emergency. Gallstone-induced acute pancreatitis, or GAP.
Yeah, it's definitely a clinical curveball we see far too often.
Absolutely. I mean, it accounts for a staggering 30-50% of all acute pancreatitis cases. So our mission today is to try and cut through some of the noise and extract the really critical evidence-based insights from our sources, specifically tailored for us as surgeons. We're going to navigate, everything from diagnosis and severity assessment to the nuanced surgical and supportive treatments of GAP, all with an eye on preventing those dreaded complications.
Like necrotizing pancreatitis, infected collections, multi-organ failure, yeah.
Exactly.
And what's truly fascinating here, and honestly often a source of significant clinical anxiety, is how utterly crucial timely and appropriate management is.
Yeah.
It really is about avoiding those most severe outcomes you just mentioned.
Right.
So we'll be zeroing in on the practical how and the evidence-based why for every key surgical intervention. Let's get started.
Okay, sounds good. So before we can even think about scalpels or scopes, we have to pinpoint exactly what we're dealing with. What are the immediate red flags, the clinical presentations that just scream GAP?
Well, the classic picture is that sudden onset, really severe epigastric pain. Often it radiates straight to the back. Patients will almost certainly report nausea and vomiting.
Okay.
Now, if you're also seeing fever or jaundice, that immediately raises the alarm bells for associated cholangitis or maybe a significant bile duct obstruction.
Right. And on exam?
On examination, you'd expect marked epigastric tenderness. And in more severe presentations, you might see the telltale signs of SIRS, the systemic inflammatory response syndrome.
So that clinical picture gives us our strong suspicion, but, sometimes those signs aren't quite textbook or we need that objective confirmation. Beyond the patient's story and our exam, what's the formal diagnostic anchor we rely on?
That's exactly where the revised Atlanta criteria come in. They give us a clear and universally accepted definition. To diagnose acute pancreatitis, you need at least 2 out of 3 things.
Okay, what are they?
1, that characteristic abdominal pain we talked about. 2, serum lipase or amylase level elevated more than 3 times the upper limit of normal. Or 3, clear imaging findings showing pancreatic inflammation.
Right. 2 out of 3. And imaging, that's where we really start to visualize the problem, right? Moving from suspicion to certainty, and then crucially, understanding the extent of the disease. What's our go-to first line?
Transabdominal ultrasound.
Hey.
It's absolutely our first line investigation.
And why is that?
It's fantastic for identifying gallstones in the gallbladder itself and any biliary dilation. That immediately points us towards the gallstone etiology.
Makes sense.
However, it often struggles to give us a clear view of the pancreas itself, largely because of overlying bowel gas. That's its primary limitation.
Okay, so when the ultrasound can't give us the full picture, or maybe we suspect something more sinister like necrosis, where do we turn next?
That's when contrast-enhanced CT, CECT, becomes our gold standard, particularly for assessing the extent of pancreatic necrosis, identifying any fluid collections, and spotting other complications. Now, here's a critical point. A sort of precision play that our sources repeatedly emphasize. CECT is best performed after 48 to 72 hours from symptom onset.
Okay, hold on. Why the delay for CECT? That sounds a bit counterintuitive, doesn't it? Waiting when a patient is acutely ill, aren't we risking missing something or delaying crucial intervention?
That's a really vital question. And the delay isn't about being slow. It's actually all about accuracy.
Accuracy. How so?
Well, performing CECT too early can significantly underestimate the true extent of necrosis. The tissue changes just haven't fully declared themselves yet. So an early scan might look falsely reassuring, kind of clean, and that could lead to misinformed, maybe less aggressive management decisions down the line. Waiting allows for the full picture of tissue damage to develop, which then guides more precise intervention.
That makes perfect sense. You want to see the full battlefield before planning the strategy.
Yeah.
Okay. What about those trickier cases? Maybe the ultrasound is inconclusive for a stone, or we need to map the biliary tree in finer detail, perhaps looking for a retained common bile duct stone.
Yeah, for those scenarios when choledocholithiasis is strongly suspected, but the ultrasound is equivocal, or you just need higher resolution imaging of the ducts, MRCP, magnetic resonance cholangiopancreatography, or endoscopic ultrasound, EUS, become invaluable tools.
Right.
They give us that detailed roadmap of the biliary pancreatic ducts, and importantly, without the radiation exposure of a CT scan. Understanding the strengths and weaknesses of each modality is really paramount for any surgeon guiding that diagnostic workup.
Okay, diagnosis confirmed. The picture is clearer. Now, the critical period begins. Our sources stress that the initial 24 to 48 hours are absolutely pivotal. They can dictate much of the patient's trajectory. What are the immediate, non-negotiable interventions?
The absolute cornerstone, without a doubt, is aggressive early hydration.
Fluids.
Exactly. But here's a critical yet often overlooked insight from the sources. Your choice of IV fluid isn't just a detail. Lactated ringers is specifically preferred over normal saline.
Why is that? I mean, fluid is fluid, isn't it?
Well, it's not just about osmolarity. It turns out LR actually reduces inflammation in the pancreas. This isn't just theory. It translates directly to better outcomes, helping avoid that cascade towards severe disease.
Wow, okay. That's important. What kind of rates are we talking?
We're talking an initial rate of about 5 to 10 milli-kV in HR, but you have to titrate it carefully based on urine output, aiming for greater than 0.5 milli-kV HR.
Got it. So fluid choice itself is almost an anti-inflammatory agent. Interesting. What about managing the patient's pain? It can be absolutely excruciating in acute pancreatitis. And what's the latest thinking on nutritional support?
Yeah, effective pain control is paramount. Intravenous opioids like morphine or fentanyl are the mainstays.
Okay.
However, a critical caution for any surgeon managing these patients: avoid meperidine.
Right. Demerol. Why is that?
It carries a significant risk of seizures, particularly with repeated dosing, because of its metabolite, normeperidine. So, best avoided.
Good point. And nutrition? NPO initially, I assume?
Yes, initially kept NPO nothing by mouth. But the paradigm has really shifted here. The goal now is early enteral feeding, ideally within 24 to 48 hours if the patient can tolerate it.
Orally or tube feed?
Either orally if possible, or via a nasogenyl tube. TPN, total parenteral nutrition, is now really reserved only if oral or enteral feeding just isn't possible. We now recognize the profound benefits of maintaining gut integrity.
Right. Feed the gut if you can. Okay, it sounds like maintaining gut function is key. Now, let's tackle two of the most critical decision points, ones that often spark debate. When to give antibiotics, and, maybe even more critically, when do we need to rush to ERCP?
Ah, yes, these are where precision really matters. Our sources are very clear. Antibiotics are not routinely recommended for sterile pancreatitis.
No prophylactic antibiotics.
Correct. There's no proven benefit, and you just risk driving resistance. They're indicated only for confirmed or highly suspected infected necrosis, or if acute cholangitis is present.
And what antibiotics then?
Typically broad-spectrum agents like piperacillin tazobactam or carbapenems. This is a significant evolution from older practices, where prophylactic use was more common.
Definitely a practice change, so no empiric antibiotics unless infection is clearly brewing. Okay. And then ERCP timing. We all know it's a powerful tool, but when is it truly urgent? Like, drop everything urgent.
Urgent ERCP, meaning within 24 hours, is reserved for very specific high-stakes scenarios. Overt acute cholangitis, that classic Charcot's triad, fever, jaundice, right upper quadrant pain, plus evidence of biliary dilation. Or unequivocal persistent biliary obstruction, shown by a bilirubin level stubbornly over 5 milli-GDL, or rapidly worsening liver function tests.
So it's not just about finding a stone, it's about active severe obstruction or infection.
Exactly. This highly specific indication is about maximizing benefit while minimizing the not insignificant risks of an urgent ERCP.
Okay. What about those cases where we suspect a stone is still there, maybe confirmed on MRCP or EUS, but the patient isn't crashing? They don't have overt cholangitis.
Excellent point. For those patients with suspected retained stones confirmed by imaging, but without those signs of cholangitis or severe obstruction, an early ERCP within 24 to 72 hours is appropriate.
So still prompt, but not middle of the night urgent.
Precisely. This allows for stone extraction in a more controlled, less emergency-driven setting. It optimizes resource use and, frankly, patient safety.
All right. So as this initial management unfolds, how do we gauge the severity of the storm? What tools do we have to keep track of a patient's trajectory? Are they getting better or worse?
We have several tools, and each offers a slightly unique lens. The modified Atlanta criteria, for instance, are fundamental. They categorize pancreatitis into mild, moderate, or severe.
Can you break those down quickly?
Sure. Mild means no organ failure, no local or systemic complications like necrosis. Moderate involves transient organ failure resolving within 48 hours, or local complications like fluid collections or necrosis or systemic complications. And severe is defined by persistent organ failure, lasting more than 48 hours, or the presence of infected necrosis. This gives us an initial snapshot of severity.
Okay, that's the Atlanta framework, but it seems like we have a whole toolbox of severity scores, BISAP, Apache 2 as well. From a practical standpoint, on a busy surgical ward, when are you reaching for which one? What's the key takeaway from each?
That's a really practical question. The BISAP score is great because it's straightforward, it's quick, and you can calculate it easily at admission to predict mortality risk.
What does BISAP stand for again?
It's BUN 25, impaired mental status, serous presence, age 60, and pleural effusion. Easy to remember. A score of 3 or more indicates a significantly higher mortality risk, immediately telling us who needs closer monitoring, maybe an ICU bed.
Okay, so BISAP for quick initial risk stratification. What about Apache 2?
Apache 2 is generally more comprehensive, and it's better suited for dynamic monitoring, typically in the ICU setting. It's good for tracking changes in critically ill patients over time, but it's more cumbersome to calculate repeatedly. So different scores for different purposes, initial prognosis versus ongoing assessment.
Got it. Beyond these initial snapshots from the scoring systems, the real art, I suppose, of managing severe pancreatitis lies in ongoing vigilance. What does that continuous monitoring look like in practice? What labs or signs are we tracking closely?
Absolutely. Continuous monitoring means daily lab work, CBC, liver function tests, amylosylipase trends, electrolytes, renal function, and importantly, trending CRP levels, C-reactive protein, can be a good predictor of severity in developing complications, sort of an early warning sign.
And imaging. Do we need repeat CT scans routinely?
Here's another key point where practice has evolved. Repeat imaging with CECT or MRI is typically reserved only if there's a clear clinical deterioration. Like worsening sepsis, new organ failure, concern for abscess formation, or other complications developing. We're really trying to avoid unnecessary radiation exposure unless it's clinically warranted. We've definitely moved away from routine follow-up scans just for the sake of it.
Okay, clinical correlation is key for repeat imaging. So let's assume the acute phase is managed, the immediate fire is somewhat under control. Now, how do we prevent the next one? The definitive preventative strike against gallstone pancreatitis is obviously the cholecystectomy. But its timing isn't just about fitting it into the OR schedule, is it? It sounds like a make-or-break clinical decision.
It absolutely is. And here's a critical, maybe almost counterintuitive insight, particularly for mild pancreatitis. The moment that acute phase passes, the clock is ticking for the cholecystectomy.
Ticking how fast?
Our sources provide really clear evidence supporting same-admission cholecystectomy, ideally within 48 to 72 hours of admission for mild GAP.
Why the rush in mild cases?
Because delaying it, even for a few weeks post-discharge, isn't just inconvenient. It can skyrocket the recurrence risk by an astonishing 30%.
30%?
30%. That's a huge clinical miss if we don't act decisively during that index admission. It prevents readmissions, further morbidity, cost. Everything.
That 30% recurrence rate is startling if we delay in mild cases. What are the biggest hurdles, do you think, that prevent us from achieving that same admission goal more often? Is it OR time? Resources?
It's often a mix of things. Or availability, yes. Patient comorbidities needing optimization. Sometimes, honestly, just old habits or logistical inertia. But the evidence is now so compelling that it really should push us as surgeons to prioritize these cases for early cholecystectomy.
Okay, so strong push for same-admission cholecystectomy and mild GAP. But what about moderate to severe pancreatitis? Does the timing change?
Yes, completely different strategy. Here, the recommendation is generally to delay cholecystectomy until the inflammation resolves substantially.
How long?
Typically waiting 4 to 6 weeks. You need that inflammatory process, any fluid collections or necrosis, to cool down and mature. Operating in the midst of severe inflammation is technically challenging and carries higher risks.
Unless?
The only real exception for earlier intervention in severe cases would be if a walled-off necrosis or an abscess specifically requires drainage during that same admission. Sometimes you might combine procedures. But generally for the cholecystectomy itself, patience is key in severe GAP.
Okay, so mild is quick, severe is delayed. Makes sense. What about dealing with any potential retained common bile duct stones around the time of cholecystectomy? IOC still have a role.
Intraoperative cholangiography, or IOC, Yes, it still has a valuable role if there's suspicion during the cholecystectomy itself. You can identify and potentially address stones then and there.
And if the suspicion is high before surgery?
Right. For patients with a high preoperative risk of retained stones, maybe they had persistent jaundice or have a dilated common bile duct on imaging, then preoperative MRCP or EUS are generally the preferred modalities. They give us a clear roadmap before we even make an incision.
Okay. And quickly, for those high-risk patients who just aren't surgical candidates for a cholecystectomy at all, maybe the very elderly, or those with severe comorbidities, are there less invasive alternatives to just prevent stone migration?
Absolutely. For that specific high-risk group, endoscopic sphincterotomy, or ES, where you cut the sphincter of Oddi to allow stones to pass, offers an alternative.
How effective is it?
It does reduce the recurrence risk compared to doing nothing, but it's important to counsel patients that it's generally less effective long-term than a definitive cholecystectomy in preventing future episodes. It's a reasonable option when the surgical risk is deemed prohibitive.
Okay, that covers prevention. But what happens when complications inevitably arise despite our best efforts? We mentioned necrosis, collections. The path forward becomes even more intricate then, doesn't it? Often needing a multimodality approach. Let's talk about pancreatic necrosis and those fluid collections.
Right, and this brings up another critical distinction: sterile versus infected necrosis. This is paramount because it dictates whether we primarily observe or intervene more aggressively.
So for sterile necrosis, what's the plan?
For sterile necrosis, the emphasis is almost entirely on conservative management initially. Supportive care, nutrition. Intervention, if needed at all, is typically delayed for more than 4 weeks. You want that necrotic tissue to demarcate and potentially wall off. Antibiotics are only initiated if infection is strongly suspected clinically or confirmed.
Okay, observe and wait for sterile. But if we're dealing with infected necrosis, the strategy shifts significantly, right? You mentioned a step-up approach earlier. How does that work?
Precisely. If we suspect or confirm infected necrosis, often based on clinical signs like persistent fever, sepsis, or sometimes gas bubbles on imaging, the step-up approach kicks in.
Step 1.
Step 1 is appropriate broad-spectrum antibiotics, often carbapenems, as they have good penetration into necrotic tissue. Step 2, if sepsis persists or the patient isn't improving adequately, is typically image-guided percutaneous drainage of the infected collections.
Sticking a drain in.
Exactly. Trying to control the source externally first. And then step 3, if drainage is insufficient or fails to control the infection, then we escalate to minimally invasive necrosectomy techniques, like video-assisted retroperitoneal debridement, VARD coming in from the flank, or endoscopic necrosectomy going through the stomach or duodenum. This whole step-up philosophy epitomizes modern surgical thinking: start minimally invasive, escalate only as needed, minimize surgical morbidity. Open necrosectomy is really a last resort now.
Makes sense. Less is more, initially. What about pseudocysts? Another common type of fluid collection after pancreatitis. If they're asymptomatic, do we always need to drain them?
No, definitely not. If a pancreatic pseudocyst is asymptomatic, observation is generally the rule. A significant number of them actually resolve spontaneously without any intervention, which is great news for the patient.
But if they do cause problems?
Right. If a pseudocyst becomes symptomatic, maybe causing persistent pain, gastric outlet obstruction, biliary obstruction or infection, or if it's just persistent and large, typically defined as greater than 5 or 6 centimeters and present for more than 6 weeks, then intervention is warranted.
And what's the first line?
Endoscopic cystogastrostomy, or cystoduodenostomy, creating an internal drainage pathway, is now considered the first-line treatment. It's highly effective and minimally invasive. Surgical drainage is generally reserved for cases where endoscopic management fails or isn't feasible. Again, that minimally invasive first philosophy.
Okay, so bringing it all together then, what does this all mean for us as surgeons on the front lines? From that initial acute presentation, through the critical decisions, to the long-term management of complications, the evidence seems to clearly guide our hand. Our sources distill, 5 core principles, almost like a surgical mantra for GAP.
Yeah, I think that's a good way to put it. 5 key takeaways. First, early aggressive hydration, especially with lactated ringers, genuinely improves outcomes. Don't underestimate fluids.
Got it. Number 2.
Second, remember that ERCP is truly urgent only for acute cholangitis or proven persistent biliary obstruction. It's not a blanket indication for all GAP. Be selective.
Okay.
Third, same admission cholecystectomy is crucial to prevent recurrence in mild cases. That's a critical preventative step we really shouldn't miss. Aim for it during the index admission.
Right. Prevent that 30% recurrence. Fourth principle.
Fourth, severe pancreatitis generally requires a delayed definitive intervention, usually the cholecystectomy, typically waiting 4 to 6 weeks for that fierce inflammation to subside and collections to mature. Patience is key here.
And finally, number five,
infected necrosis absolutely demands that structured step-up approach. Start with targeted antibiotics, move to percutaneous or endoscopic drainage as needed, and only then escalate to minimally invasive necrosectomy if absolutely necessary.
So it's a very logical progression.
Exactly. And if we connect this all to the bigger picture, it's really about synthesizing these critical points into a holistic, patient-centered approach, one that prioritizes precision, minimizes invasiveness whenever possible. And as our sources emphasize, effective management of GAP truly requires strong multidisciplinary collaboration.
Yeah, it definitely sounds like a team sport.
It really is. Between surgeons, gastroenterologists, interventional radiologists, critical care, everyone has a crucial role. But those key decision points, early resuscitation, precise ERCP timing, appropriate cholecystectomy timing, the step-up approach, they're integrated components of reducing patient morbidity and preventing recurrence.
It is indeed a complex landscape, isn't it? But one where these clear evidence-based guidelines can really make all the difference for our patients. So thinking ahead, given that significant recurrence risk, even after treatment, and the evolving landscape of minimally invasive techniques we've discussed, what future innovations do you anticipate might further refine our surgical algorithms for gallstone pancreatitis? Could anything challenge today's established gold standards? What might be on the horizon for us?
That is a truly provocative thought. Perhaps better ways to predict severity even earlier, or maybe even more refined, minimally invasive techniques for necrosis.
Sure.
It's certainly an area that continues to evolve.
Something for us all to keep an eye on. Well, we hope this deep dive has provided you with some valuable, practical insights to potentially apply in your own practice. Thank you for joining us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.